Hi everyone, and welcome to today's Pulmonary Fibrosis Foundation Disease Education Webinar Series. My name is David Lederer. I'm a Senior Medical Advisor for the PFF and a pulmonologist and ILD specialist in New York. Today's talk is going to be on hypersensitivity pneumonitis, which is one of the more common types of pulmonary fibrosis. I do want to point out before I begin that nothing I say today is medical advice. I'm not making any medical recommendations. I'm only providing information that you can then take to your healthcare provider and talk about whether any of the information I've provided is relevant to your health. Here's an outline of the talk. First, I'm going to start with a description and definition of what hypersensitivity pneumonitis is. Then I'm going to talk about how healthcare providers diagnose hypersensitivity pneumonitis, and then talk a little bit about different ways in which it can be treated. And finally, I'll end with a little bit about what it's like to live with hypersensitivity pneumonitis. Some of you may have seen this picture before. This is one way that we think about the family of interstitial lung diseases and the family of diseases that we call pulmonary fibrosis. So the large circle, the gray or brown circle, represents all of the lung diseases that we know about, including diseases like COPD, which stands for chronic obstructive pulmonary disease, asthma, and cystic fibrosis. Within that large family, there's a smaller family, the first blue circle, and you can see the words interstitial lung disease, or ILD. Many of you are familiar with that term, and that's a family of lung diseases in which inflammation or scar tissue or both builds up in the walls of the little air sacs in the lung, and I'm going to illustrate that a little bit more. Within the big family of interstitial lung diseases, there's a smaller family called pulmonary fibrosis, and this is not one disease. It's a family of dozens of different diseases, all defined by the presence of scar tissue in the lung. Now, how does hypersensitivity pneumonitis fit in? Well, there's the answer. That orange circle is hypersensitivity pneumonitis, which I've abbreviated HP. And you can see that that orange circle falls both in the pulmonary fibrosis family and it crosses the border into the interstitial lung disease family as well. So that means that many cases, or many people who have HP, will have scarring in the lungs, many will have inflammation in the lungs, and some may fall out here where there's inflammation but no scar tissue in the lungs. By way of comparison, a related disease called idiopathic pulmonary fibrosis would fall squarely within the pulmonary fibrosis family, would not overlap with interstitial lung disease, at least in the non-fibrotic form. It is a type of interstitial lung disease, but within the pulmonary fibrosis family. And technically, idiopathic pulmonary fibrosis would also not overlap with hypersensitivity pneumonitis. It would be its own separate circle. Now, I want to make sure everyone is on the same footing, so I'm going to give a little bit of background about interstitial lung diseases. As I said, these diseases are a family of diseases affecting the interstitium of the lung. The interstitium literally is the walls of all of the air sacs in the lung. And you can see over on the right, this is a microscopic view of the lung, and I'm outlining, if you can see my little tiny mouse cursor there, I'm outlining the walls of the air sacs in the lung. Those walls are the interstitium. And if scar tissue or inflammation were to build up in those walls, which I'm going to show you here, it could make it hard to breathe. It could lower oxygen levels. So here is a close-up view of what I just showed you, and I'm showing you O2 here in pink and CO2 here in blue, and those stand for oxygen and carbon dioxide. And the oxygen has to move from the inside of the air sac through the wall of the air sac into the bloodstream. Carbon dioxide has to move from the bloodstream through the wall of the air sac into the inside of the air sac so you can breathe it out. Now, if there is a buildup of scar tissue, which here is in this teal color, these thickened walls here, it's going to make it much harder for oxygen to get into the bloodstream. And this is the primary problem in pulmonary fibrosis. And as you can see on the top of the slide, I wrote scar tissue and inflammation slow down the flow of oxygen into the bloodstream. So oxygen levels can go down. You can certainly feel quite short of breath with this disease. And of course suffer from significant coughing as well. So again, in a general sense, before we talk more specifically about hypersensitivity pneumonitis, why do these diseases occur? Why does scar tissue build up? Why does inflammation build up? So in general, there's some kind of injury to these cells, which are the tiny little components of the lung, and then healing occurs, but not in the right way. If healing occurred in the right way, then you'd end up with normal, healthy tissue. But instead, the healing is part of inflammation and scarring. Now, at hypersensitivity pneumonitis, we kind of have a sense of what the injury is. It turns out that this type of interstitial lung disease is due to breathing in particles in the air that are from, usually at least, from living things, with the most common triggers being exposure to mold and bacteria and birds. Sometimes the exposures are certain chemicals. So breathing these things in can trigger injury and inflammation in the small airways of the lung and then in the lung tissue itself. And some people have inflammation, some people have scarring, and many people with HP have both. And this slide is simply meant to show you that it's not just the environment, and we'll talk more about those factors in a moment, but some people are predisposed and others aren't because of their genes, and we don't really understand why two people exposed to the same trigger might not both develop HP. One might and the other might not. So as I said, the major cause of HP is exposure to airborne proteins or chemicals. Now in my practice, mold is the most common trigger that I see, and I'll explain in a moment where the mold comes from. But I also see HP due to birds living in the home, birds that are in cages or coops that people might be taking care of. We saw a couple of people where we thought the bird exposure was in their friend's house, and they would visit their friend and be exposed to the bird there. And in addition, certain chemicals that are used in the workplace or occasionally in the home can do this. That's much less common. And I've explained that genetics plays a role, but again, we don't really understand that too well. Doctors often think about HP in two different ways. We call one of them acute HP and the other chronic HP. Acute HP mostly is inflammation that we might see on a CAT scan, or if a biopsy of the lung is done, we might see inflammation in the lung tissue under a microscope. Now this form of HP sometimes can be very serious. People can be very ill in the hospital, sometimes not. And the good news is that often it is partially, or in some cases, completely treatable with medications. And I'll mention one of those later, but they're usually medications that weaken the immune system, like prednisone or other steroids. I've underlined that it is critical to remove the exposure. If it's mold or birds or whatever it turns out to be, if you have HP, whether acute or chronic, you should completely avoid those exposures in the future. Chronic HP typically means that scar tissue is present, with or without inflammation. But the scar tissue can be seen on the CAT scan or on a lung biopsy, or both. And again, the inflammation can be treatable to some degree, but unfortunately the scar tissue is not treatable. And again, I'll reinforce that it's critical to remove the exposure from the home or to move out of the home. Those are the two main strategies. So how is this disease diagnosed? Well, first, people show up to my office. People show up because they're breathless when they're exerting themselves. and they might be suffering from a very bothersome cough. We call it a dry cough because it usually does not involve a lot of sputum. Some people have some thin sputum sometimes in the morning. Many people have fatigue or low energy. And then the doctor listens to your lungs and might hear crackles or what we call squeaks. These are both very important findings that a doctor can hear in your lungs. Then if we suspect that interstitial lung disease or HP is present, we'll do a CAT scan, which might show areas of inflammation or scarring. And as I mentioned, in some cases, a biopsy of the lung may be required. There are other tests and procedures that can also be done depending on your individual situation. Now, I know there's a lot of words on the screen here. I do want to just illustrate some of the similarities and differences between IPF and HP. So in IPF, we generally don't have an understanding of what the cause of the disease is, whereas in HP, by asking certain questions, we might identify sources of mold or birds or other triggers in the home or other environment that could be a major cause of the disease. When a doctor listens to the lungs in IPF, we hear crackles, but no squeaks. So crackles sound like Velcro being ripped apart, and squeaks sounds exactly like it sounds. It's a squeaky little sound when you take a breath in. Generally, you can't hear it, but we might be able to hear it with a stethoscope. So in IPF, usually no squeaks. In HP, sometimes or even often, we will hear squeaks. We can also see differences on a CAT scan. In IPF, the scarring typically occurs on the outside edge of the lung, near the ribs. Now that doesn't mean outside the lungs, it's still inside the lungs, but it's along the outside edge of the lung. The truth is we can see that same pattern in HP, but we also see other patterns. We will see scarring in the center of the lung where the big airways are and the blood vessels are. We also can see inflammation, and you might hear doctors use the word ground glass. When we use the word ground glass to describe the appearance on a CAT scan, we simply mean there are hazy areas in the lung, and those hazy areas could be inflammation. It could be other things too, but in some cases are inflammation. And then you may hear doctors use the word mosaic, and what we mean by that is that there's a patchwork of hazy and dark areas in the lung, kind of alternating patterns. And I'll show you an example of that. And you may also, either on a CAT scan report or from your doctor, hear about gas trapping or air trapping. And this is just a finding on a CAT scan that suggests that there's inflammation or scarring in the small airways of the lungs, which sometimes we see with HP. Now, if your doctor does a biopsy of the lung and looks under the microscope, she or he will see a usual interstitial pneumonia or UIP pattern in IPF, whereas in HP we see a different kind of pattern. We see inflammation and scarring like we saw in the CAT scan. And I'm sorry, I'm missing one quotation mark there, but we often see something called a granuloma, which should not be a frightening word. Sometimes people see OMA, O-M-A, and they think of a cancer or a tumor. This is not a cancer or a tumor. A granuloma is simply a certain type of inflammation in the lung or other organs. Granulomas does not always mean HP. There are many diseases that can have granulomas, and I've also had plenty of people who have HP who don't have granulomas, but it can be helpful diagnostically if we see that on the biopsy. I'll also point out that while IPF is often around the edge of the lung in the biopsy, HP is often around the airways of the lung. So in many cases, by carefully looking at a lung biopsy, we can often distinguish between these two conditions. In most cases, however, it's all of these things combined that help us point towards one disease or the other. If you've seen us give webinars or presentations before, you may have seen this slide before. This is an example of a CAT scan of someone with IPF, and I know it's a little bit hard to look at. I will point out that in the center, everything that looks gray and white, those are blood vessels and parts of your heart and even fat tissue and bone in there. But on the left side and the right side, where it looks very dark, those are your lungs, and they're reversed. So on the left side is the right lung, and on the left side is the, sorry, did I say that right? Yeah, on the left side is the right lung, on the right side is the left lung, and the dark areas are the healthy areas. You can see those two blue or teal arrows pointing to very dark areas of the lung. Those are healthy areas. But then the other areas where the orange arrows are pointing have lots of extra white lines and gray areas. That's scar tissue in the lungs. And if you can see, there's a little squiggly black arrow. I don't know if you can see it on the left upper there, but that's pointing to a little airway that's pulled out to the edge of the lung. That's called traction bronchiectasis, something else you might see on a CAT scan report. That's simply more evidence of scar tissue in the lung. I'll point out that the dark areas are in the center of the lung and the scarring parts are along the edge of the lung. That's how I described idiopathic pulmonary fibrosis. That's what this represents. On the next slide, and I'm sorry it might be a little bit blurry, but on this slide it's a good example of HP. And this is, I apologize, a little bit of a typo. This is from a recent publication from Kevin Flaherty. This picture is not from Kevin Leslie. So in the center again are blood vessels. This is the right lung on the left side and the left lung on the right side. The white arrows are pointing to dark areas, and the green arrow is pointing to hazy areas. So the dark areas might be normal areas, and the hazy areas are probably areas of inflammation. Sorry. And I hope you can appreciate and see that there's a bit of a pattern here where there's some dark areas next to gray areas, then alternating with dark areas again. That patchwork pattern is what we call mosaic or mosaic patchwork pattern. People use different words for that. So this would, to me, suggest the possibility of HP. I will point out that I don't actually see much scar tissue on this CAT scan image, but maybe in different parts of the lungs, we're only seeing one part of the lung. Maybe in other parts of the lung, there might have been scar tissue. Well, what treatment options are available for people living with HP? So just like for other forms of pulmonary fibrosis, smoking cessation is critical. Very important. Now, if you have HP, it's important to try to find what caused it, what we often call the trigger. You may also hear doctors use the word antigen. Antigen just means a protein that is literally the trigger. The antigen refers to the molecules that are doing it, but I think trigger is probably a better word to use. If your doctor determines that you need oxygen or should enroll in pulmonary rehabilitation, those can be excellent treatments for people living with HP and other forms of pulmonary fibrosis. Now, you may have been asking yourself, well, how do I know if I've been exposed to mold? Well, there can be some clues. The biggest clue might be a damp home or areas of dampness in the home or in the workplace, or if you have another residence like a summer home or a condo that you go to once or twice a year. I've certainly seen plenty of people where HP was in their summer home, for example. You may also see, I apologize for the typo, but you might see visible water damage in your home, damage in the floors, the walls, the ceilings. Stains are a major sign of water damage. Or you might know about mold. You might have seen it, or there might be musty areas of your home that smell like mold. I will point out that ventilation systems, in particular forced hot air systems, are a place that mold likes to grow. And so if you have a forced air system and you have pulmonary fibrosis, you should talk to your doctor about whether or not that's a possible trigger of your disease. If you use a humidifier or hot tub, that could also be a source of mold or bacteria to grow and cause pulmonary fibrosis. And then birds, in addition to having actual birds in the home, there now have been studies showing that the use of down or feather pillows and bedding or even down winter coats could trigger this disease. Now, in some cases, your doctor might recommend that you have an environmental inspection of your home for mold, and that certainly can be done. There is no standardization that I'm aware of how that is done, and sometimes it can be difficult to interpret the results. So any findings from a home inspection for mold should be discussed in detail with your doctor. Your doctor may also decide to order blood tests to see if you've been exposed to certain kinds of mold or to certain kinds of birds. In some cases, these blood tests might be helpful. In many cases, they might be misleading by being negative when you have been exposed to mold, or being positive when mold is not the cause of your disease. So those blood tests and even the home inspection all need to be considered in the context of everything else going on with your health. I mentioned supplemental oxygen. If you do experience periods of low oxygen levels in the blood, you should certainly talk to your doctor about whether or not oxygen can be beneficial for you. It is often prescribed to keep oxygen levels over 88 to 90%. In some cases, this might reduce symptoms of breathlessness, and some doctors, but not all doctors, recommend that patients use a pulse oximeter pictured there to measure your oxygen levels at home. This is something you should discuss with your doctor. Some of you may have been enrolled or even currently participate in pulmonary rehabilitation, which is a structured exercise program to help improve symptoms and quality of life and exercise capacity in people living with advanced types of lung disease such as pulmonary fibrosis, often done in the outpatient setting, often about 8 weeks, 2 times a week, and includes supervised exercise. What about therapies for HP, medications for HP? Well, in addition to oxygen and pulmonary rehab, and of course removing the trigger from your home, sometimes medications can be helpful. One commonly prescribed medication is prednisone, which falls in the family of steroids or corticosteroids. And if there's significant amounts of inflammation in your lungs, or your doctor thinks it might be worth trying, many people will receive drugs like prednisone. I will point out that there are also other drugs that can weaken the immune system, like prednisone does, that may have different sets of side effects, and I encourage you to talk to your doctors about those many different other types of medications. And very importantly, that there really is no one right way to manage or to treat HP. It all really depends on the details of your health and your preferences and values. So sometimes medications are a good idea. Sometimes use of medications might not be consistent with your preferences and values because of concerns about safety or side effects. In some circumstances, there might be no inflammation, and therefore the medications may or may not be helpful. So it's important to discuss all treatment options with your doctor. And there are now some clinical trials of drugs to treat HP, to treat the scarring in HP, and we're really excited. It's still going to take a few years to see if those drugs work, but some of the new antifibrotic drugs will be studied in HP. Lung transplantation is an option for some people with HP. Lung transplantation is the replacement of one or both lungs with 1 or 2 lungs from a donor. And about 1,000 people with pulmonary fibrosis undergo lung transplantation each year in the United States. It's a pretty small number. We know there's probably 130 to 200,000 people living with pulmonary fibrosis in the United States. So it is a rare procedure, but it can be quite effective at relieving breathlessness and cough. In general, people don't need oxygen anymore, and if given at the appropriate time in the course of the disease, lung transplantation often helps people live longer and better lives than if they didn't have a transplant. Now, lung transplantation is a big topic. There are many risks and complications that some people face after a transplant. I will point out that early referral, meaning making your first visit to a transplant center at an early point in the course of your disease, is very important so that they can educate you about the disease and have sufficient time to send you through testing. I'll also point out that there's really no firm upper age limit, and each transplant program has their own criteria based on age as well as based on many, many other factors. Finally, I want to wind down with what happens after diagnosis. Well, you get your diagnosis, your team will work together, and that's often not just your pulmonologist, but there's a radiologist reading your CAT scan. There might be a rheumatologist involved if you have an autoimmune condition, a pathologist involved if you've had a biopsy, physical and respiratory therapists, nurses, and of course your primary care doctor, ideally all working together as a team. I think we're all familiar with the challenges of communication despite having electronic health records, but ideally these folks are communicating at least through letters, if not by phone calls. Very common question I get is, well, what's going to happen to me? I have pulmonary fibrosis, or in this case I have hypersensitivity pneumonitis. What are things going to look like in 6 months or a year or 5 years or 10 years? And it really is impossible to answer this for a specific person, but in general there are some ways to think about this. The first thing is that if there's no scar tissue, if the HP is interstitial lung disease but doesn't fall into the family of pulmonary fibrosis, meaning if there's only inflammation, then that person might not progress. And I've certainly had people who I've been following for 10 years or more who had a more inflammatory form of the disease, were treated, maybe have remained on low doses of treatment, and are perfectly fine and healthy 10 years later and still doing well. They might have a little bit of scar tissue in their lungs, but it's stable, and generally, as long as they're not exposed to that trigger, they're healthy and doing well. So that's the good part of HP. If there is inflammation, as I said, we can treat it. Sometimes it goes away or improves. But many people with HP have a more serious form of interstitial lung disease, and by that I mean that scar tissue is already present in the lungs. And as I've mentioned, the scar tissue is not reversible. I've seen many people who have chronic HP, meaning they have the scar tissue there, where we've treated any inflammation that's there, and we've removed the trigger, which could have been mold or something else in the home. And yet, their disease progresses even though we've gotten rid of the trigger and even though we're treating the inflammation. And I would say that this is actually more common than not. And I wish I understood exactly why people continue to progress even though we get rid of the trigger. And I don't have a real answer for that, but I think it's simply that these diseases are much more complex than we make them out to be. And even though we might say we know the cause of this disease, there are probably still unknown, undiscovered contributors to HP, in addition to genes and in addition to mold or other triggers. For an individual person who has scar tissue, as I said, no one can really predict what will happen over time. Are you going to be healthy and stable in 6 months? Are you going to be healthy and stable in 2 years? What are things going to look like in 5 years? No one knows. You might be exactly the same, you might be a little better, or your disease may have progressed by that point. Everyone is different, and it's important to have regular follow-up with your doctor so he or she can monitor the course of your disease, and if things are getting worse, then he or she can do some additional testing, for example, a CAT scan or blood work, and try to sort out why things are a little bit worse, and then try some other kind of treatment to see if it might be helpful. What does progression mean? Progression means buildup of inflammation, buildup of scar tissue, and that leads to worsening of symptoms, increased breathlessness. If you have no breathlessness now, and then later your disease progresses, you might initially become breathless when you're exerting yourself, walking upstairs, walking quickly. Eventually, if the disease becomes severe enough, progression can be being short of breath, even sitting in a chair or barely moving around. coughing can get worse, and the need for oxygen and the amount of oxygen needed can also increase. I mentioned monitoring. Your doctor might monitor your disease over time by doing lung function tests, which are also called pulmonary function tests. The most common of which is called spirometry. That's the one where you take a deep breath in and then blow out as hard and fast as you can. And I know you hate that one, but it's actually one of the most useful ones for us. We may also do exercise tests, like a walking test, often called the 6-minute walking test, but there are others. And occasionally a CAT scan of the chest so we can reassess what the lungs look like. Kind of broadening again back to pulmonary fibrosis in general, you should know that there are pulmonary fibrosis support groups. They're largely sponsored by the PFF, at least in the US. And you can find a list of our support groups and search for them by state on our website, pulmonaryfibrosis.org, and then you click on Life with PF, and then click on support groups or search for support groups there. You might also find help or communities that you can connect with at websites like patientslikeme.com and rareconnect.org. And then I'll also refer you to our website. The Pulmonary Fibrosis Foundation website has many different resources. We have our Patient Communication Center staffed by Lori Price. And you can email her or call her at pcc@pulmonaryfibrosis.org or at 844-TALK-PFF. All of our webinars, including this one, are archived on our website, so you can go and view a webinar whenever you like. We also have plenty of educational materials on the website, including a recently updated patient guide. It has lots of information about pulmonary fibrosis. And of course, you can always find care centers in our PFF Care Center network, as well as many other ILD medical centers on our website. I'm going to end with questions, and I have 5 questions I want to take you through. The first one is, how can I be certain that I have HP and not IPF? And that is, I think, a terrific question. And it sometimes is very difficult to tell the difference between the two, even for a doctor and a doctor team at a PFF care center or other ILD specialty center. It's not always obvious that it's one or the other, and I do see plenty of people who seem to fall in between the two. But as I mentioned earlier, there are some clues that can help distinguish one from the other, both based on exposures in the home or workplace, based on how the lungs sound, based on how a CAT scan looks, and if required, a lung biopsy could, if safe, it's not always safe to do that, but if you're otherwise healthy and the doctors aren't certain exactly which type of ILD you have, a biopsy can sometimes be a helpful thing, and that's important to discuss with your doctor. The second question: is HP different from NSIP, which stands for non-specific interstitial pneumonia? So NSIP is the pattern that we see in the lung under the microscope when there's inflammation and scar tissue that's otherwise hard to characterize, meaning that it's not a pattern that we would see in IPF, it's not a pattern we would see in HP, but there's still inflammation or scar tissue with no other defining features. And we have labeled that non-specific interstitial pneumonia. Again, it's a pattern that we see under the microscope. Now, some people have NSIP for reasons we can't understand. It occurs in an idiopathic fashion. Idiopathic means we don't know the cause, just like idiopathic pulmonary fibrosis. But idiopathic NSIP is a different condition. Sometimes we know the cause of the NSIP pattern. For example, someone might have an autoimmune disease or might have been exposed to certain medications that might have triggered the inflammation or scar tissue in the lungs. And in general, HP and NSIP are considered to be different diseases or different patterns under the microscope, but in some cases there is substantial overlap between them, just like we see overlap between HP and IPF sometimes. To really be certain that an NSIP pattern is present, you generally require a lung biopsy, although sometimes a CAT scan might be enough in some circumstances. The third question is, if I get rid of the mold in my home, will my HP go away? Well, I guess the best answer is sometimes it might. But in many circumstances, getting rid of the mold won't make it go away, might make it a little bit better, or it might not make it better, but might help slow down future progression, or in some cases, might not make it better, but might stop future progression. So it's not a cure, getting rid of mold, in most cases, but I do think it's helpful in many cases. The next question is, will pirfenidone or nintedanib help my HP? Well, there's a lot of interest in studying whether these two drugs, which are FDA approved to treat idiopathic pulmonary fibrosis in the U.S. and approved in many countries outside the U.S. to treat IPF as well, there's much interest in whether or not these two drugs might help people with HP. There are clinical trials that will help us answer these questions. Today, there's no answer to that. But I'm hopeful that in the very near future, meaning a year, 2 years, maybe longer, we might begin to get some answers about that. And I've begun to get this question quite a bit. Should everyone have their home checked for mold? And should everyone get rid of birds and get rid of their down bedding? And that's a very tough question. It's hard to make a recommendation like that that would affect millions and millions of people. So I can't really speak on behalf of the Pulmonary Fibrosis Foundation, but personally I think that there's enough risk that people should at least very seriously consider the risks that mold pose and consider the risks that birds and down bedding pose. So getting educated is the first step, and then each person can make that kind of decision on their own. Of course, in consultation with their doctor, perhaps. So that is the end of this webinar. I want to thank each of you for joining me. I hope it was helpful. We look forward to your feedback about how we can improve webinars and make them relevant to your day-to-day life. I do want to thank our two sponsors, Boehringer Ingelheim and Genentech, for support of these webinars, and I hope to see you at our next webinar. Thank you for joining us.